the Medical AI Podcast.
Hello, I'm Dr. Felix Beacher, and this is the Medical AI Podcast, a 30-minute thrill ride of big ideas. We talk to a range of top guests, from industry innovators to scientists to philosophers. This is brought to you by Omdia and Informa Tech, where I'm the head of healthcare technology. Infertility affects 1 in 6 couples worldwide. Virtus Health is a leading provider of fertility treatment with more than 40 fertility clinics, mainly in Australia, Singapore, and Europe. I'm joined today by Peter Illingworth, a medical director at Virtus Health based in Sydney, Australia. Peter was involved in the development of Virtus Health's AI system for identifying viable embryos for use in fertility treatment. Peter, a huge thank you for joining.
My pleasure, Felix.
Okay, all right. So let's start by just briefly describing what Virtus Health does.
So Virtus Health is a large IVF clinic. We started from a few small clinics, and what we aim to do is to promote better success rates through the development of new technology. So we've tried a number of things in the past. Infertility is a major problem that affects many couples who are trying to have their families. It has gone up a little bit. It has increased recently, particularly, I think, as families tend to delay having their families until they get older, perhaps because of professional careers. And it's a very complex process, helping people have their family.
Okay, all right. Let's cover some background. Now, you've mentioned one possible cause of rising infertility there. First of all, is it true that fertility is on the rise? And is that a Western phenomenon or what?
Two different things are happening. One is that there is a slow, steady increase in the incidence of fertility in Western countries, thought mainly to be due to people delaying their families later. But what's also happening around the world is this technology is becoming much more accessible around the world and much more widely used. So there's a huge growth, for instance, of IVF in countries like China, where the technology is being very quickly rolled out and used on a very widespread basis.
Okay, now, so you've focused on one possible cause of the rise in infertility, which is people having children later in life. It's also been posited that there may be environmental factors. Is that something that you think should be discussed as well?
There's a lot of controversy around that. There are strands of evidence that suggest that in men have more problems having children than they used to do. But the statistics around all of that is horrifically complicated, and there are plenty of people who are skeptical that this is a real phenomenon.
Is that right? Because you'd imagine the sperm count, for example, is a pretty easy thing, in principle at least, to perform. I mean, you'd think that might be a fairly objective measure of male fertility that you can track.
It is, but the methods of calculating a sperm count vary a great deal, and the way that it's measured now has changed a great deal from the way it was measured 30 or 40 years ago. So it is not easy to simply say that sperm counts are falling. But what's also more complex is that a sperm count is not the same as fertility. The vast majority of men have healthy sperm counts, and so if a sperm count changes from being very high to just high, is that a real change that matters? It's an amazingly controversial area with strands of evidence heading in both directions.
Okay, so could you briefly describe what IVF is and how it works?
IVF is a process where a woman will have medications to stimulate all of the eggs at that time in her ovaries to grow. Normally an average of about 10, but anywhere between 5 and 25, depending on the number of eggs that are there in her ovaries at the start of the treatment. So the eggs are collected, the eggs are taken to the laboratory, they're joined with the sperm, and then embryos develop from there, and they grow, nowadays normally grown for 5 days. And during that time, the embryo does some weird and wonderful things, which we'll come back to. And then at that point, the embryos are either transferred back into the uterus or are frozen for future use.
Now, Virtus Health developed a very interesting AI system for assessing the viability of embryos for IVF treatment. So, can you describe this AI system? What does it do?
So the starting point for all of this was when we moved to incubators with cameras built into them to take an image of the embryo every 10 minutes. We saw a lot of things that surprised us. It had always been assumed before this that an embryo would start at 1 cell, 2 cells, 4 cells, 8 cells, and continually, steadily divide to reach the shape that it is at 5 days. However, when we went back and looked at these videos of the time lapse, weird things were happening. Cells were going in, cells were coming out, cells were growing in odd places. And the question of all this, what does any of this stuff mean, and what does it tell us about which embryos will turn into healthy babies and which will not? And the human eye couldn't do it at all. So what happened there was that we had a chance conversation with a brilliant young medical student who specialized in computers and artificial intelligence. And he came to us and said, I can fix this. And so he built in his own rooms his own computer to do this with double flow fluids, the cooling system, an amazingly powerful home built computer. And he took all the videos of these embryos and ran them through the computer and taught the computer to recognize the embryos that led to babies at the end. And by running this through again and again, the embryos went through a training process. And once they went through a training process, we then tested them on the other embryos to see if the training process was valid. And what we
I see. So, sorry, go on.
yep. So what we do from there is that we then went back and compared it with a human embryologist looking at the embryos. And typically, an embryologist doesn't look at the embryos growing for 5 days. He can't or she can't. And what they instead do is they look at the appearances on day 5, and there are a lot of formalized grading systems developed to assess embryos and see which ones have a better chance of becoming a healthy baby than others. And what we did was we had to compare the effectiveness of the AI system, which we christened Ivy in the early days, and we compared Ivy with our embryologists, and we went back through thousands of embryos. We published a study involving 10,000 embryos across 1,800 patients, and we looked to see which was better. And when you're testing a diagnostic system such as this, for the capacity of the diagnostic system to diagnose an embryo which will become a fetal heartbeat, you use a piece of mathematics called a receiver operator characteristics based on the area under the curve. Now, that's a fairly simple system that a ROC score of 0.5 means a totally random selection, while a ROC score of 1 means utter implausible perfection. So what we did was we compared these two. We compared the embryologist and Ivy, our AI system, in this way.
Okay, all right. Before we get onto the results of that study, let's go back a couple of steps. Now, what precisely is the problem that you are addressing here? You could, for example, just get embryologists to continue to use their standard methods for testing embryos, right? I mean, but why not just do that?
Well, the problem that we're dealing with, which is one that has been part of IVF since the very beginning, is how do you know which embryo is going to give a woman the best chance of having a baby as quickly as she can? And as well as looking at formalized grading systems, people have studied the genetics of embryos, people have studied the metabolic activities of embryos, and it's become a sort of holy grail of IVF to try and find some sort of technique that will allow women to go to the best embryo first and speed up the time that it takes for them to conceive. And that's the challenge.
Okay, and so could you give a little more detail on how these standard methods for assessing embryos is done? What kind of features would an embryo be looking for?
So an embryologist looking at an embryo will be looking to see how far the blastocyst has expanded. Now, the word blastocyst, as its name implies, contains fluid in the middle of the embryo. And from day 4 to day 5, that fluid gradually expands, so that an embryo at the end of 5 days of growth, which has a lot of fluid in it, is a more advanced embryo. They then look at the appearances of the cells. Now, by the time an embryo gets to day 5, you can see very clearly the cells that are going to lead to the baby, called the inner cell mass, and the outer cells that will develop into the membrane placenta, called the trophectoderm. And you can look separately at these two cells and look at the appearances of the cells. How healthy are they? How well divided are they? How complete are they? And they give a grading system, either A, B, or C, for each of these factors. And on that, an embryo will end up with a complete grading, which is related to its chance of turning into a healthy baby.
Okay, so just to be clear, what we're talking about here, when we say embryo, you see, people might be thinking about an embryo as something the size of, I don't know, a monkey peanut or something like that. We're actually talking about a tiny clump of cells that can only be seen through a microscope, right?
That's correct, exactly. It's an embryo
Okay.
starts at one cell. From one cell onwards, once the egg and sperm have joined together, it's called an embryo. And then it develops from there for 5 days to become around about 300 to 400 cells.
Okay, so you took an image every 10 minutes over 5 days.
But that's correct.
For the stage in which the embryo was growing from a single cell to something like 4 cells, right? And you stitch these single images together into a kind of high resolution microscope video, essentially. Is that correct?
That's exactly what happened. We have a video which you can look at, roll through, roll backwards, and for every embryo, each embryo has its own video.
Okay, so from a technical point of view, this is a very interesting AI system because it uses video input, which is pretty unusual in the field of medical AI. I mean, you might have thought it would be simpler to just use single images, like an image of, I don't know, day 10 or something like that. Did you experiment with that kind of thing?
It never entered our heads to do this. And now the reason that it works here, as opposed to other medical contexts, is that the video is incredibly structured. It grows from day 1 to day 5, the same number of images, very standard video, and every video is at exactly the same time point. Whereas if you're looking at a heart, for example, the movements of a heart on an ultrasound machine, it would be much harder to get that level of standardization to make it work. And after all, it was the video that drew us in the first place. It was looking at these videos, looking at these strange cell movements and understanding what was going on with those that made us think of using AI in the first place.
Okay, so let's come back to this question of how you tested the accuracy of your AI system, Ivy, against that of human experts. So could you just tell us again, how can you quantify the difference in accuracy between humans and AI systems?
So you plot a curve and you measure the area under the curve. And if the area under the curve is 0.5 of the square, then that's a random selection, total chance, no predictive value at all. If you get the area under the curve to be 1, that is complete perfection, which is simply biologically impossible. So when people have looked at when people have looked at embryologists predicting which embryo will lead to a fetal heart, then the general assumption is that a good embryologist will come in at 0.65 to 0.7, giving a receiver operator characteristics of 0.65 to 0.7, which is pretty
So
good.
roughly speaking, that's like 65%, 70%
Yeah, roughly.
accuracy.
Yeah, exactly. That's a rough way of putting it. Yeah. So we compared the same thing using the AI system that by this time had taught itself on thousands of embryos, and it was now being tested on thousands of embryos. And we found that the area under the curve for the same comparison was 0.93, incredibly good at predicting which embryo would turn out to be a the one that would give them the fetal heart.
Yeah. So, I mean, it's hard to overstate the hugeness of that result. I mean, we're talking about 65 or 75,
Yeah.
65 to 70% accuracy versus 93%, 95% accuracy. And it's a huge difference. So were the human experts upset? Did they feel, were they upset that they'd even taken part in this study? I mean, how did they feel about it?
Look, I think there's no doubt there was a little bit of nervousness. Are we going to lose our jobs and be replaced by an AI system? But in fact, assessment of the embryos is only one part of it. And the second thing is that you still need the embryologist to look after the embryos, to nurture them. The embryologists still have a look at the embryos, and we really are still a little hesitant to hand over all the decision making to an AI system. So in practice, what we are tending to do at the moment is to use both an embryologist and the AI system. And the hard part
Yeah.
really mainly creeps in when the embryologist looks at 3 or 4 embryos and thinks they're all roughly the same. And that's where the AI system comes in. An embryologist can still tell you a really awful embryo or a good embryo, but it's the ones that look the same where the AI system comes in.
Got it. Okay, so the AI systems are more useful for the hard cases, essentially,
Yeah.
right? Okay, so now this is a kind of stunning result. I mean, it's a very powerful instantiation in my mind of the power of medical AI in general. I think it's a wonderful case study. Obviously, it was Carl Sagan who said that extraordinary claims require extraordinary evidence. Now, how can you support that claim? What kind of study did you use to establish that result?
Right. So there are a number of ways of looking at this, and we do have to provide strong evidence before we get too carried away with all of this. In the first study we did, we looked at 10,000 embryos. So now, since then, we sold this product to a company called Vitrolife, who have inserted it in their incubators around the world, and they have retested it again on another 100,000 embryos. And the same observation holds good. The area under the curve remains 0.94 on the much larger study. So what we're seeing is real. It's not a statistical artifact. However, we still have to go back and ask the question, does this really work in a prospective environment? So if you turn the question around from did it work in these 100,000 cases that have gone backwards, if you go forwards and you prospectively compare it with an embryologist, does it actually do better than an embryologist? And that's why we've gone through this process of doing what's called a randomized controlled trial, where 1,000 women, just over 1,000 women, have been have selected at random to either have their embryo chosen by the embryologist using the standard grading system, or to have the embryo for transfer chosen by AI. And also to see if we see embryos that the embryologist thinks are not very good, but AI thinks is good to freeze and keep for the future, we will at random decide whether it's the AI or the human who makes the decision. And that's a very important thing. The basis of medical knowledge is randomized controlled trials with sufficient power to answer questions. And there are really two different questions to be answered here. The first question, which might seem stupid, but we still have to validate it, is AI even as good as a human? Because there are a number of advantages of using AI in a laboratory, which we'll come back to in a moment or two, but we still have to show that it's as good as a human in a prospective randomized trial where all the other factors are eliminated through the randomization. And the second question is AI actually an improvement on the human in a prospective randomized trial where, again, all the other factors are ironed out? So we've almost completed this trial. But this is very important evidence because this evidence will identify what is the future role of this AI system.
Okay, so let's talk about the benefits of this kind of system? Which may seem a silly question, but I'd like to know precisely what those are. So could you speak to that?
Yeah. So I think AI systems such as this have two possible advantages. The first is that they save time, and if they can be more efficient, then that brings down the cost to consumers of going through a technique like IVF. The second is that they're relatively error proof, that human beings are great things and we all love having human beings looking after us, but as human beings, we do make mistakes from time to time. Human judgment is fallible, and therefore a digital system can identify errors. Again, digital systems make mistakes as well. So having a combination of a human being and a digital system gives you possibly the perfect answer for getting success. The most important thing that we're looking for, though, is the question of whether it's actually better than a human being. And if it's better than a human being, then it allows a woman to more quickly go to the best embryo. And that for her will allow her to have the chance of getting pregnant more quickly. And remember that IVF is no fun at all for a patient who's going through it. And the smaller number of embryo transfers that she has to do, the better for her, the easier the process gets. Hence the whole incentive to study this area in the first place.
So what are the kind of side effects to the woman patient from IVF?
Yeah. So every time a woman goes through IVF and she takes the drugs and her hormones are stimulated to go very high, she can often get a sense of bloating and discomfort from her ovaries. And in a small number of cases, she can become unwell with that. She can accumulate so much fluid that her tummy can swell up so much that she has trouble breathing. That nowadays, fortunately, doesn't happen very often. But clearly, going through IVF is a physically demanding process and emotionally demanding as well. So the sooner you can make it work, the better.
Okay, all right. Let's talk about the potential drawbacks or risks with this kind of system. Are there any? And what do you think they are, if there are some?
Yeah, look, the drawbacks are that it doesn't work for every single embryo. There are a couple of situations where AI doesn't work. The first is that where an embryo has had a biopsy done to take cells off for genetic testing, which is quite a common thing, then the AI system can't handle that at all because the cells move in a different way because of the biopsy. So our system at the moment only works where there's been no biopsy done. The second thing is that every now and again an embryo will move in the incubator out of the field of view of the camera because the well is slightly bigger than the camera. So that means that you can't rely on getting a result for every single embryo that's in the laboratory. Around about 95 to 96% of embryos give you a result from this, but not 100%. So sometimes you may still need a human being to look at the embryos themselves.
Hmm.
And, and,
Okay.
and you all,
So, sorry, go.
finally, you always worry with any artificial intelligence system of an inbuilt bias in it. Is it choosing things for the wrong reasons? And that's a major concern of any AI system. But the randomized trial will tease that out by prospectively testing the system in a clinical environment. In a randomized trial, we should see that quite clearly.
Okay, let's talk about the bias issue. Um, this is an issue that critics of medical AI talk about a lot. And in particular, people are often focused on biases to do with race or other factors that may present disadvantages in some kind of socio-economic way. Now, have you tested your system for things like that?
Yes, we have. So what we've done is we have laboratories all over the world which operate with slightly different culture media, slightly different incubator systems, and we've run this on videos from all over the world. And what we can see so far is that there's no geographic variation, that in different laboratories using different culture medium, because one of the biggest sources of bias in this area is if culture medium changes the appearances of embryos, it may be detecting that rather than inherent property of the embryos themselves. So we've deliberately checked that out very carefully and can't find any difference in the use of this system in laboratories using quite different culture systems. We can't see any difference in male or female embryos. We can't see a difference there either. That doesn't seem to affect the endpoint. And so far, we can't find any systems of bias, but that's not to say they don't exist. So far, we haven't found any.
I see. Now, this is a good example of a black box system, which means that you don't necessarily know what kind of features that the algorithm is focusing on. Is first of all, have I understood that correctly? Is that correct?
Exactly? That's exactly it. We did not set out with any preconceptions. It's a true deep learning system which sets up with no preconceptions, no preset parameters. It looked at the videos and made its own mind up from the videos.
So, I mean, sometimes in machine learning, it is possible to explore which kind of features are most important for discriminating between, for want of a better term, good and bad embryos. Now, do you have any idea at all what kind of features the system is using?
Yes, we tried to drill back into that to have a look, and in fact, from the background of basic biology, this is actually a really, really important question. What is it about an embryo's growth that makes it the one that will work as opposed to the one that won't? So we haven't yet worked that out yet. What we can see is that the period between day 2 to day 3 and the last few hours of growth appear to contribute most to the predictive value of the system. But exactly what's happening at those times and what are the factors, still not very clear at all.
Now, is this black box issue something that you find yourself having to defend the system against? I mean, do regulators, I don't know, doctors, maybe patients, do they focus on this as being an important issue?
Not that we've seen. Remember that it's different from other areas of medicine where the factors and the causation are already very clear. Before we started doing this sort of stuff, nobody really had any idea from a biological perspective why some embryos work and some don't. So a black box in this is nothing new in this area.
One thing that might seem a little bit puzzling is why these kind of systems, if they are so superior to human expert embryologists, haven't just completely taken over the entire market for IVF, or have they? Can you speak to that?
Well, what we can see in practice is that we sold this system to an incubator manufacturer based in Sweden called Vitrolife. And Vitrolife have installed this system into every incubator that they now manufacture and sell. Now, the reason it's not completely taken over is that we are still struggling to understand its role. We can see that the predictive value of the AI system is higher than the predictive value of an embryologist, but we still haven't got enough confidence in the prospective clinical data to say this is how we will use it. So it's a lovely toy. It allows us to deal with the more difficult embryos, so the embryos that are close together where the embryologist can't distinguish between them. The AI system gives an advantage in that area. But how you use and compare an embryologist and the AI system in the everyday clinical workings of an IVF laboratory is still not quite clear. So it's being widely used, but we're not widely replacing embryologists yet.
Okay. And how competitive is the market for these kind of AI systems?
So there are
for IVF?
Yes, there are a number of them in development. Ours was, I think, probably the first to reach the stage where it could be used in clinical practice. But there are a number of others under development using slightly different systems. There are some that are based simply on looking at the embryo on day 5 and studying that one image. There are others that look at embryos at different time points using different AI methodologies. So it is quite a competitive area, and it's likely that other tools will emerge and that IVF clinics are looking to invest in this sort of technology will have a range of products to look at in the next 5 to 10 years.
I see. All right. Well, Peter, let me ask one last question, and that is got nothing to do with fertility or IVF, and that's just the question of what personally your favorite example of medical AI is?
I think it's still imaging. I think that imaging is the easiest place to apply AI, where you've got a very standard set of parameters for the system to look at. The big challenge that will come over the next few years is, can you make AI work on clinical data? And clinical data is so messy, it's so untidy, it's so much more challenging to do. But an AI system that can take a medical history and diagnose disease on the basis of a medical history would be a marvelous thing indeed.
Well, Peter, it's been an absolute pleasure spending the last half hour with you. So thank you so much for appearing. And it would be great to have you back on the podcast another time. Thank you so much.
It's been my pleasure, Felix. Thank you.
Thank you for listening. I'm Felix Beacher. Ping me on LinkedIn for more information on Omdia's services in healthcare technology. See you next time.